Hello, Dr. Maluccio, Dr. Blakely, and Dr. Del Rivero. Good morning. We have some real good questions for you guys today. And let's get cracking. So, okay. All right, good. They really make me work hard here. Okay, good. All right, so, oh, wow, okay. Keep them coming. We have afternoon session as well, guys. We'll try to get as much as possible. All right. So, interesting question. If a neuroendocrine tumor expresses somatostatin receptors, does that always mean that tumor is functional? Dr. Maluccio, why don't you take that?
I think that's a total Del Rivero question. We've already decided the surgeon's over here, Aman. The surgeon's over there.
Hey, you just said the largest surgical experience. All right, we'll hand it over to Dr. Del Rivero.
Of course, I'm happy. And I also, as you know, Dr. Chauhan, I just want to say he's a national and an international recognized NET expert. So we're really honored that you're here and leading the Q&A. So I just want to say that. And thank you, Dr. Chauhan, for all of your efforts. So in terms of the question, let me just repeat the question. The question was about if all tumors that express somatostatin receptors are they functional, and the answer is no. So the functionality relies on symptoms as well as biochemical evaluation, meaning what we can find in the blood. The somatostatin receptor avidity is independently of whether the tumor is functional or not. The fact that the tumor is expressing the somatostatin receptors, it tells me that it could be eligible, the patient may be eligible for Lutathera or PRRT with Lutathera, but also it tells me, guides me as well where the tumors are and in the extension as well of where the tumors are. But it has nothing to do with the functionality, because the functionality is determined on symptoms as well as biochemical evaluations. And we have a series of hormones that we check when we feel or think that the tumor is functional.
Great, fantastic. I completely agree. Just to add one little thing on that, majority of our patients are non-functional. Okay, so it's just a small minority, and between published literature, some says 5%, some goes all the way to 30%, but it's somewhere in that number. So majority of our well-differentiated NETs have somatostatin receptors, but they are not functional because that tumors are not secreting those vasoactive peptides or amines or hormones. Wonderful. Hey, I finally found a question for you, okay? This time you cannot bounce it. Can you explain the connection between lymph nodes and NET tumors, and why do they drain the tumor? So this is the reason why I didn't get into surgery, because I hate anatomy, and our surgery colleagues are really good at that. So it's a good question.
So, so lymph nodes are like a spider web, and they drain your entire body. And so there is no operation for which you would be able to take entire lymph nodes. And so we are looking at drainage of the lymph nodes in a regional site. That is no different than taking colon cancer and draining taking the lymph node basin that is draining that portion of the colon. The small bowel, as Dr. Blakely showed you, showing that mesenteric mass, that's within the mesentery, that's the lymph node draining. Breast, we go in under the arm. Melanoma, we go in like in the groin and wherever the draining lymph nodes are. So in general, the lymph node is trying to trap it and keep it from getting beyond that localized area. But the fact is that if you were to look at something like a midgut neuroendocrine tumor, is that it goes from the sausage, that's the primary site, then it goes into the lymph node basin, which is in the mesentery, but having actually gotten out of the mothership and into the draining lymph nodes, regardless of what cancer you're talking about, it has just raised significantly the likelihood that cell will have acquired the mechanism for which it can then spread and become metastatic. And I think that what's weird about neuroendocrine, is that you have an ungodly number, like 60% of patients with a midgut, node-positive midgut neuroendocrine tumor will either present with or develop metastatic disease over their entire lifetime. Okay? It doesn't take away from the fact that it is very slow growing. Patients can live a long time even in the setting of stage 4 disease, but that it's that burden of an ongoing risk of something propping up over 10, 15, 20 years, the need to be on an injection for 10, 15, 20, 25 years, the syndrome and the dietary and behavior modification required to keep those symptoms in check. That's the burden of a disease regardless of how long you live. So if you were to go on to some of these support sites, no one is like sitting around the campfire singing Kumbaya about the fact that you live a really long time with it. They're talking about how do you get through the mental burden of knowing that something can happen over your lifetime and the need to be on treatment. So I know I extrapolated on that, but the lymph node basins is critical to the way that we stage and locally control that area in hopes of diminishing the local recurrence rate and the need for additional therapy at that site. Did you want to add?
No, I think that's a perfect summary. I can't make it any better.
All right. Thank you so much, Dr. Malucha, for that. Next question is, how often do we find incidental appendiceal neuroendocrine tumors, and is right hemicolectomy done? I mean, is it necessary? Dr. Blakely, why don't you take that one?
No, that's a great question. So we do a lot of appendectomies, and it's less than 1% of the time that we find a malignancy in the appendix. The most common malignancy of the appendix is neuroendocrine tumor. Less commonly, people will have an adenocarcinoma similar to what we see in the colon. But the right hemicolectomy, it's a great question because one of the fundamental problems of incidentally finding a neuroendocrine tumor is that we don't have complete staging because we don't take lymph nodes in general, or maybe we take one periappendiceal lymph node, and that might be negative, but that may not be completely staged. And so one thing that we were interested in was looking at what are prognostic factors. How can we guide the decision to go on to get a right hemicolectomy, or really, I would say a good ileocystectomy, taking only a few inches of the colon and a few inches of the end of the small bowel, is probably adequate to get enough lymph nodes to adequately stage. And that's where certain pathologic criteria on the report are helpful. So if somebody has lymphovascular invasion with that neuroendocrine tumor in the appendix, I think the value of going on to get that colon removed is much higher. Whereas if it's a small tumor, so less than a centimeter in size, completely removed, so it's in the mid portion or the distal portion of the appendix, not at the base, with clean margins, those are other factors that would say it's less beneficial to go on to get a right hemicolectomy or ileocystectomy, and that the appendectomy is adequate treatment. So small tumor, no lymphovascular invasion, clean margins, those are the things that we can tell even from an appendectomy pathology report to say we've performed adequate treatment, we don't need to go on and get more lymph nodes. But it's all relative. I can't say that even with all of those favorable criteria that somebody's going to have a 0% chance of lymph node involvement. It's going to be a single-digit percentage. But that's where we get into number needed to treat. So to do 50 colon resections for one potential involvement of lymph nodes, that's where the risk-benefit equation gets a little bit trickier.
Thank you. I'll add a little comment on it. So lately, AJCC, the American Joint Cancer Committee, roped me in to write a paper just on this particular topic. So we're working on the next guideline chapter on appendiceal nets. So, and we have, like Dr. Blakey mentioned, very limited data, especially in the tumors where there are certain risk factors, be it tumor size, for example, 1 to 2 centimeter of appendiceal net. What do we do? Should we let it be, or should we go for more extensive surgery? So there was a very interesting paper published earlier this year in a very prestigious journal called Lancet Oncology. And the study was done in multiple centers, about 40 plus centers in Europe. And what they found out that even if patient had lymph node involvement or 1 to 2 centimeter appendiceal nets, the overall survival did not change between the patient who got just a simple appendectomy versus right hemicolectomy. However, there's a big caveat here. When we went into the weeds of the data, only 15% of patients were followed with imaging 10 years out, right? So these are usually young patients. So we don't really know if this trends out 20, 30, 40 years, right? So we still have our skepticism I don't think we still have a right answer, should right hemicolectomy be completely avoided or not in these patients with high risk factors. So we really have to individualize the treatment, like Dr. Blakely mentioned.
Yeah, and I think that's a very important point because we talk about lymph nodes a lot, but fundamentally removing lymph nodes usually across cancers does not impact overall survival. It really impacts what we call recurrence-free survival. And so that's where it's prognostically important, and having that information may formalize surveillance and monitoring over time, and that's where the benefit is identifying recurrence of disease at an earlier time and an earlier stage, as opposed to waiting 10, 15, 20 years and then symptoms develop and then it's diagnosed.
Correct. All right. Next question would be very apt for Dr. Del Rivero, as she's dual board certified in oncology and endocrine. I don't know how you had time for that, but so how would you treat a lung NAT patient with Cushing's syndrome?
Yeah, that's a great question. And if the patient with a lung neuroendocrine tumor has excess of hormone, in this situation cortisol, the first thing that we always need to do is block that excess of cortisol. And the reason why is because, like, for example, if it's a localized neuroendocrine tumor that is producing cortisol and surgery is indicated, I still would like to control the excess of cortisol. How do I do that? There are medications that block the excess of cortisol. One of them is ketoconazole, the other one is methiropone. So there are medications specifically to block the excess of cortisol. And I usually like to do that if surgery is indicated. In the situation where surgery is not indicated, and I have a patient that is having excess of cortisol causing Cushing's, and for example, in the advanced settings and when there is tumors everywhere in the body, the likelihood, like we discussed earlier, that surgery may be indicated in that situation may not be likely, but yet the patient still has a tumor that is producing excess of cortisol. In that situation, the best way to address that is by removing the stimulus, which is the adrenals. And that's usually what we do. We recommend to resecting both adrenals. That said, adrenals are important because they produce cortisol. Cortisol is a hormone, a stress hormone. So we usually replete that after the adrenal glands is removed, but at least we're removing the stimulus and they're not producing this excess of cortisol. So I think there is two scenarios here. When it's localized and it's producing excess of cortisol, I provide medications to block that excess, and then after I do surgery. In the situations where it's advanced and it's metastatic, meaning that it's everywhere in the body, the likelihood that surgery will be indicated is not likely. In those situations, the best way to remove that excess of cortisol is by removing the adrenal glands. And that way, if there is now, in that situation, we make the patient what we call adrenal insufficiency, and that in those situations we replace with hydrocortisone. But that's true. That's a situation why neuroendocrine tumors need a multidisciplinary team to address all of those issues.
Absolutely. I just wanted to add that. Yeah, please make sure the patient has a multidisciplinary team to take care of, including endocrinologist, oncologist, and the surgeon, because it really needs the village to take care. Next question. How soon after showing on scan should a peritoneal, should a biopsy be performed? Looks like they're talking about a peritoneal tumor. And when not all tumors can be, if not all the tumors can be biopsied, what type of tumor should be biopsied? Dr. Malucci, do you want to take that?
Yeah, so that's all going to depend on the extent of disease. So if you have a CT scan showing a calcified mesenteric mass or even a mesenteric mass, that's actually very characteristic of a midgut neuroendocrine tumor. We do not actually need a biopsy of that to drive decisions. You are allowed to get a PET scan if you've got a mesenteric mass that is suggestive of a neuroendocrine tumor, and so then the PET scan gives you both the diagnosis and the extent of disease. Now, if you've got metastatic disease, though, or someone has it on a colonoscopy and they go in and they see the tumor, they will biopsy the primary site. But if you have something sitting in the liver, say, for example, you get in a car accident, you get a CT scan, you've got something in the liver, we'll just go after the liver. So that the grade, just so the grade is more important than the stage, right? And so if you've got something that is stage 4, then it's going to be really important that I understand the grade, because in neuroendocrine, we always treat to the highest grade. So people can have mixed grade. And so it's not saying that it's uniform. I'm sure that we've all seen it where you've got a lower grade in the liver, but that in general, the liver is going to be the driver of the decisions at that point. We'll biopsy the liver.
Yeah, I completely agree. In fact, there's published data from University of Iowa on this, that there could be a grade discordance up to 30% of time, out of which 20% of times there could be an upgrading into different, and then 10% time there could be a downgrading. So my mantra is always to go after the most distant site or the metastatic site. But if you have luxury to do both in one sitting, that is even better. Dr. Blakely, why don't you take this one? So what is the risk of radiation-induced liver injury after Y90-based embolization? I know we are sort of missing our IR colleagues here, but surgeons almost as good as IR. I'm kidding.
Wow. Fighting words. It's a good question. I think there's been a lot of reluctance in general to operate after Y90 because of the radiation effect and scarring on the liver, in the sense that it doesn't cut normally, it doesn't respond as well to the maneuvers we use to control bleeding. But I think it's also, sometimes it's better than expected. And so I would not say that a history of undergoing Y90 precludes any surgery after that. I think it does change a bit of the risk in the sense of bleeding, but it's not prohibitive. We usually try to reserve the Y90 for when we say it's unresectable. But then, of course, if a patient has a really good response and a combination of ablation and resection might finish clearing the liver, that might be a consideration. But I'd be interested to hear your experience too.
Yeah, so most of my fellowship work was in the non-surgical management of secondary tumors in the liver. I think for the most part, if I were to just say, I don't know how they do it at the NIH, is once PRRT was on the horizon, I think most of the neuroendocrine subspecialty centers really went away from Y90, and I don't want people to say, oh, well, then you have to pick and choose. If you were to look at, and we do actually have liver oncology coming, but if you were to look at the different platforms that we use for liver-directed therapies, the overall response rate is actually the same, regardless of whether or not you do a bland embolization like they do at Memorial Sloan Kettering, or a chemoembolization like they do at Johns Hopkins, versus Y90, which they have sort of pioneered at Northwestern, so that the techniques are for a lot of different subtypes. And so there's no actual benefit, or at least known benefit, of using yttrium Y90 the way that we do it in liver oncology, not in Europe for PRRT, but Y90 that we use here. It's a significant dose of it, and I hate operating in the setting of a liver that's had Y90. So, but if it's the higher grade, and therefore you're trying to maybe add a little bit of the radiation effect, and you do not have a good reason to be going there and operating, Y90, you can really, you can radiate an entire lobe of a liver or segment of a liver with Y90 that you would not get the same type of downstream effect with the other platforms. That's just not the strategy that we usually use in neuroendocrine. We're talking about leaving our options open, not burning any potential bridges. So for the most part, and I'd like to see what Dr. Casson says, but for the most part, in interventional oncology, you have people that would say unequivocally, do not put it on the menu for neuroendocrine if you think other treatments are going to be required, including PRRT. And you have some that will publish papers that say it was safe, but that I think that without long-term data on that, and without having long-term data on the combination of PRRT and Y90, I think we've just veered away from it.
Yeah, I would agree. Our practice have moved away from using Y90. It's because we live in the era of PRRT, and most of our well-differentiated neuroendocrine tumor patients would at some point in time receive PRRT, which is a radiation-based treatment, right? And there is no data, head-to-head data, that one form of liver-directed therapy, be it bland embo or chemo embo or Y90, is better than the other. So because of that, there is this theoretical risk of adding external, radiation-based injury. However, on the other side of argument, there is data which has been published recently suggest, at least in the short term, there's no radiation-induced liver damage. But what we are really worried about is long term, because our patients live for years and decades. During my training, when inherited a lot of patients who gotten Y90 long time back, I've seen patients dying from liver fibrosis and end-stage liver disease who had prior Y90. Of course, these are anecdotes. I don't want you to kind of judge the whole field based on that. There's a lot of places people still do Y90. But because of the growing role of PRRT, I'm getting more and more skeptical till I have long-term safety data in PRRT era that this can be safely done. The next question is, all right, how can I find out about getting involved in clinical trials, especially in this region? Maybe our DC colleagues can chime in about it. What's your strategy? How do you guys find and guide patients about relevant clinical trials?
I can start, and maybe Dr. Blakely.
Sure. For me, it's usually patients find us. Sometimes providers refer them, but a lot of times it's a Google search. I mean, a lot of my patients, they reach out, and our emails are a matter of public record as being federal employees, and that's where a lot of referrals come from. And I think that's where advocacy groups such as this one are really important to help guide patients.
Right.
So this is where it's a mutually beneficial arrangement for us to be here together, because then you get to meet us, we get to meet you. But that sort of community resource is not something that we are built to provide. And so there's a major niche where groups like NCAN are really critical for patients and providers to get to know each other.
Yeah. And just absolutely agree with Dr. Blakely. And one thing that I want to mention is in terms of clinical trials, there are different clinical trials. We have treatment trials, we have natural history study, we have surgical trials as well. And at the NIH, I have to say we're fortunate to be in a place that we have all of those trials in terms of treatment trials specifically for neuroendocrine tumors, and we're building on that. We also have the natural history study that allows us to follow the patients long term to understand more about the natural history and be able to understand about how can we improve the quality of life, how can we improve the care that patients receiving with neuroendocrine tumors. We also have, I have to say, superb surgeons here at the NIH, Dr. Blakely as well, Dr. Hernandez, who operates on our neuroendocrine tumors, and they have, Dr. Blakely showed you earlier what they do after they resect the tumor, and to me that's kind of like the state-of-the-art research as well, because that they will be able in real time to be able to determine what works for those patients, because they want to do drug testing, and I think that's something that to me is very exciting to see. So that's why whenever I meetings like this, is like I feel hopeful, because I think we're learning more about neuroendocrine tumors. We have more the experts. Dr. Chauhan has to say, I don't know if you sleep, Dr. Chauhan, but she has so many treatment studies, really trying to make a difference in patients with neuroendocrine tumors. And I would like to know your thoughts about clinical trials as well, because you really are on top of treatments and clinical trials, and really very advanced. So, but yes, I have to say that thank you, because I think without you, we wouldn't be able to have the clinical trial. So you are the most important equation here, and I really appreciate everything that you do.
Yeah, I completely agree. I was just having a chit chat with one of my colleagues yesterday about these things, that how just in front of my own eyes, I'm relatively new in NETs. I started getting exposed to neuroendocrine tumors during my LSU days with the real NODA guys in 2013, and then I got trained with Ed Volin and Lowell Anthony in Kentucky 2015. And, just in last 10 years, I've seen like an explosive growth in the amount of drug development, interest, advocacy, both from industry and, federal, NCI, FDA, and of course, patient advocacy groups like NCAN and so many others. And all of this has really catapulted the whole field from one trial to several trials, from one drug to now multiple options, which is always a good problem to have. We recently co-authored a paper, how to sequence our treatments, because For example, pancreatic neuroendocrine tumors, we have options include somatostatin analog, everolimus, sunitinib, PRRT, CAPE-10, and then a host of clinical trials. It's a good problem to have multiple options. So regarding how to find trials, of course, locally, NET specialists can guide you, and that's why I encourage people to seek a local NET specialist for at least 1 second opinion, so they can guide you. And other resources, clinicaltrials.gov, which is, again, government free resource. You put a search word in it. Make sure you use the appropriate filters like active trials, so that you're not really looking at the closed studies. And it lists you all the places where the study is open and gives you a contact number. You can give that the contact number a call and see how things are. One of our West Coast colleague, Josh Mailman, devised a software to kind of really help through finding clinical trials. Check that out as well. That's an easy resource, but it feeds the data in from clinicaltrials.gov, so it's reliable. So there are all these avenues, but talking to your oncologist, especially a NET specialist, would get you the best filtered information, which is relevant to your particular case.
Okay, can I get on my soapbox?
Yeah,
Aman's going to be like, is Maluccio going to get on her soapbox again? So the thing about clinical trials, I think that patients have to recognize one. They have to recognize the different types of trials that were mentioned, the phases of the trials, and what the role and what are the goals of a particular trial. Two, that the clinical trial requires you to then go to and from. I think the NIH has a friggin' awesome thing where they will literally supply the transport. We have a housing unit in New Orleans where people that if they're coming to New Orleans can stay at our housing unit free of charge, so that it's not as much of a burden onto it. But the reality is that what we have not done a good job on is that a patient in particular in the South, they cannot afford to be driving to, Kentucky or to this. And so you have huge swaths, like you have the whole middle of the country too. So Iowa, we kind of all work together and we're like, isn't that Iowa? like I think we just need to send it. And so I think what we're trying to achieve is that they become more multi-institutional, so that all of us decide, hey, I think this may be a game changer. But if it's going to be a game changer, that means that we have to incorporate the neuroendocrine subspecialty centers that are ultimately responsible for advocating to patients that cannot cross state lines for their care. And so I think more and more as the clinical trials open, I think we will have it be so that you wouldn't have to travel so far to get there, because that would probably be the biggest reason why someone will not participate in a clinical trial, is what is required in that follow-up period. And in neuroendocrine, because people live a long time, it can be 1 year, 2 year, 5 year trials where you're coming back and forth.
Great. We'll talk a lot more about the clinical trials in the afternoon session. Next question, I think it'll be a good one for Dr. Del Rivero, and I'm trying to club all the similar sort of questions together. So it's regarding capecitabine temozolomide. We call it CAPE-10. Dr. Del Rivero, can you explain when you use CAPE-10? And there's a similar question. It's a case scenario. Please don't take this as a medical advice, but we'll try to kind of just give you general educational points. If a patient was treated with CAPE-10 for 2 years for pancreatic NET, metastatic to liver, and experienced minimal growth, then took a break after 2 years, and now has a faster tumor growth, can they restart CAPE-10 again at a higher dose?
First, let's answer the question about the indications of CAPE-10. As I discussed earlier, capecitabine, temozolomide, they are both chemo pills. And the indications, based on what we know, is mainly for pancreas neuroendocrine tumors. When to use it on the sequence of treatment, and that's something that we kind of discussed earlier. For example, if I have a patient that have newly diagnosed pancreas neuroendocrine tumors that have many tumors, we call that large volume of tumors, and is symptomatic, and my goal is to shrink the tumors, my first inclination is to start capecitabine temozolomide first. And the reason why is because we know, based on the data that was recently published, that CAPE-10 can shrink the tumors compared to other treatments, and most of them stabilize the tumor. Some of them may shrink, but not the 40% that we have seen with capecitabine temozolomide. Sometimes we give Cape-10 to shrink the tumors, and sometimes that makes feasible for a patient to have surgery later on. Now, in terms of the second question about that, it was Cape-10, minimal growth, had a break, and then rapid growth. I think in that situation, what I would do is a biopsy, because I need to understand whether the tumor is changing in behavior. Sometimes what we have seen is that the tumor goes from well-differentiated to a little bit more aggressive, for which the treatment algorithm may change, and Cape-10 may not be necessarily an option there. And also, if I see that I see some growth on capecitabine temozolomide, I may not necessarily go back to capecitabine temozolomide. What do you think, Dr. Chauhan?
Yes, absolutely. In fact, I was just discussing with one of the patients outside the role of biopsy at progression, especially in the case like this where 2 years had gone by and patient did really well. Now all of a sudden the tumor is growing very fast. So anytime there is change in the behavior of the tumor or the natural history of disease progression is changed, you always worry about change in the biology of the cancer. So the only way to confirm is a biopsy. So please get the biopsy, because that will help us tailor the treatment. So for example, if this was a high grade 2 or low grade 3 well-differentiated NET, and now it's a high Ki 67 well-differentiated NET, we might tackle it a little bit differently. We might actually recommend platinum-based chemotherapy as compared to maybe rechallenger Cape-10. However, having said that, if there was no convincing reason for progression on Cape-10, always keep it at the back pocket. We have very limited options, so I definitely don't like to burn our bridges. So maybe if we don't have to restart Cape-10 now, but it's good to know that this could be a potential options. Cape-10, what we have learning, and this is a process of evolution. I used to use Cape-10 for a long period of time as well. And then we started learning about long-term risks of Cape-10 and myelodysplastic disease, and we started giving breaks after a while. These days, I don't even do it more than 9 months. So after 9 months, I give a break. Because after 9 months, we don't really see a lot more shrinkage. And these side effects on bone marrow could be cumulative. So I don't want to stress the bone marrow and give the break. And whenever the tumor does come back, I always have the option to either restart it or try a different treatment and restart Cape-10 at a subsequent progression. So since the tumor hadn't progressed, I would keep this in a back pocket, re-biopsy, see what's going on, to reevaluate what your options might be. See, in the 2 years time period, our options have also evolved, right? So you might be a candidate for a clinical trial. You might be a candidate for everolimus or something else. So that would be my take on it. There is next question about how many studies are being done worldwide on oral therapy for tumor control and symptom control to replace monthly injections. Dr. Malucha, do you want to take this? Because okay.
That would be a question for Dr. Chauhan.
Yeah. I don't know how many there are, but we got one.
Without getting in trouble with my friends who do injections here, I love injections, somatostatin analogs, be it lanreotide or sandostatin, I think is the most important treatment that we have. It's a backbone of our treatment. It works. It has the longest track record. It's very safe and doesn't cause all those terrible side effects that we're talking about. It does have some issues, but not those terrible chemo side effects, right? So I'm a big believer in that. However, there are many patients, probably even here, who've been on these shots for a really long period of time. I personally don't like injections. Sometimes I faint. So I can imagine if somebody's getting these shots for 8 years, they probably really want a break, right? So we were clamoring for a drug which is an alternative route of administration, be it a pill. We finally, somebody answered our call, and there is a clinical trial that is evaluating a drug called paltusotine. It's an international study. It's open a few sites in Europe, a few sites in Asia, a few in South America. But we at Kentucky were the first site to open it. And we put some patients in. It's an ongoing study, and we are also opening it in Miami. I think New Orleans is considering it. So it'll be open in various places. However, that study right now is looking at only functional control, so flushing and diarrhea control. Of course, we are going to think about the next generation of study about tumor control after that. So progress is being made. If you are interested in knowing more, please reach out to us as well. The good thing about that study, and we really advocated hard for it, because I'm also a big advocate for out-of-pocket patient costs, because they add up. So the study actually pays for logistical support, travel support, and maybe to some extent hotel support. So that's really neat. And also it's a short study. So a 2-month trial. So if you do respond to the pill, you will have access to free drug for about 1.5 years, 2 years after that. You're free to continue it. Okay? So a lot of really perks, and we try to make it very patient-friendly. Okay? So
and could I add, one onto that, is that if you just look at the relevance of some of these things, not taking away, obviously, the standard of care benefit of the injection therapy, is that if you look at part of the country, so in the South, probably greater than probably 80% of our market share comes from greater than 50 miles away. And so the cost, whether or not it be the travel cost, the burden of getting those injections that require an infusion center. So when you think about just even if it was just for symptom control, or it pans out as being better, I don't see it necessarily as a competitor. But for people in like rural Arkansas, rural Mississippi, where getting to an infusion center is a huge burden for them, I just found that just the idea that there would be an oral form of a serotonin inhibitor is potentially a game changer. So for me, the benefit of that trial is that for patients that, not just because they hate getting a jab, that's bad enough, but that for patients in rural parts of this country, it would potentially be a game changer and be more cost effective.
And there's, on the similar thought, and we'll talk a little bit about it in the afternoon session, there's also another drug which is a subcutaneous injection, and patient can do it themselves at home. It's done every 2 weeks, and that's also under trial. So it's like, how people give insulin, so it's a much smaller needle. That I think I won't faint with, but so there's a lot of drug development happening in this space. Okay. All right, next question, and and one of you, anybody can take this. If you have a non-functional pancreatic neuroendocrine tumor, but have had flushing with drinking red wine, why does the flushing occur? And I'm adding a question, another myself. Should they stop drinking red wine?
Maybe it's menopause.
I'm not sure. It was not me, it was her.
No, the tannins in red wine are known to make you flush. Could it be that it is because it's signaling through the serotonin receptor? I think that in patients that have carcinoid syndrome, oh yeah, they can say that they can take like one little sip and it will set something off. But I think that the symptoms that people have with red wine and those sort of vasodilatory type of things are known with red wine. I usually tell my patients, just drink white wine.
Yes, I think it's important to make distinctions between these syndromes, I think, as a broader question, right? So the typical carcinoid syndrome is from elevated serotonin, which is primarily made by midgut or the small bowel nets, and not the early stage, usually when they're advanced and involves liver. So they almost always have liver mets. Now, some exception to that might be ovarian drop mets because it bypasses some of the blood supply. So we have seen carcinoid syndrome without really a lot of liver mets in those situations. The other exception is lung nets. Lung nets can also, minority of lung nets can secrete serotonin. But other subsets of neuroendocrine tumor like pancreas, they usually tend to, if they are functional, tend to be insulinomas. They secrete high insulin, so very low sugars. Or VIPoma, not the kind of VIP we want, vasoactive insulin peptide, so terrible amount of diarrhea. Glucagonoma, I even had a grelinoma. And there are so many hormones that we haven't even yet discovered, right? So I agree with Dr. Maluccio. It could be an alternative reason, hormone or drug, or and if you really want to confirm, get your serotonin or urinary 5-HI get checked. If that is high, yes, that would explain that. Okay, there is some trigger for serotonin with the foods. All right, there are a couple of yes. we are about 18, 17, 15, 16. Do you want to take one last question? And then we'll keep... So many good questions, guys. Fantastic.
They can be answered in the afternoon, right? Because we have an afternoon session.
We will carry them over. Let's do one last one. Okay, carcinoma heart disease. What tests are used to access or evaluate carcinoma heart disease? And yeah, how about that? Dr. Blakely, what do you guys do for screening carcinoma heart disease at your place?
That's a good question. We will generally check blood levels of chromogranin A and serotonin. I think the echocardiogram is really important, and so we'll involve our cardiology colleagues. Because I think particularly we have to consider this whenever we're going to talk about surgery for somebody, and making sure that the heart is healthy enough. And we know that left-sided heart failure, we have a lot of different treatments for. Right-sided heart failure, we don't have as much. And so that can be, that sort of carcinoid heart syndrome can be a major exclusion criteria or contraindication from major surgery. And it's not something that we can really fix as easily. Be interested to see what Dr. Maluccio says.
Oh, yeah, no, I totally agree. So anyone that comes in with a mid-gut elevated serotonin, we get a baseline echocardiogram that it has very characteristic changes if the valves have been associated with that. We do that because there's often a delay in diagnosis, and so we don't know how long that patient's been living with those elevated serotonin levels. Now, if you get an echocardiogram and it does not show any changes consistent with carcinoid heart disease, and then you take out the primary and the serotonin level goes down, we do not routinely continue to follow echocardiograms without there being an indication, because it is a serotonin-driven phenomena. So then I'm saying, well, I don't need it for this indication, although I still might need it if we're considering a surgical procedure or things like that. But that for the most part, that anyone with an elevated serotonin level, I get a baseline echocardiogram. And in people with really bad carcinoid syndrome and persistent elevated serotonin levels, metastatic, neuroendocrine, I will get those every year.
Great. Dr. Del Rivero, any comments?
I just wanted to add that there was a recent study where a possible indication for carcinoma heart disease is the brain natriuretic peptide, BNP, in the studies it said that now maybe checking that in patients with a small bowel neuroendocrine tumor could definitely give a lot of information, because that could be an indication of early carcinoma heart. And as Dr. Maluccio and Blakely also mentioned, is about, when do we do echocardiograms in a patient with a small bowel neuroendocrine tumors? And like they mentioned, if it's normal, we're not necessarily going to recommend an echocardiogram. The question is if it's twice the upper limit of normal, 3 times the upper limit of normal. I mean, Dr. Chauhan, I would love to know your thoughts, but usually if I see serotonin levels, 5-HIA levels twice the upper limit of normal, I will be more inclined to recommend an echocardiogram and follow with a cardiologist. And also checking, as I say earlier, the brain natriuretic peptide. Another, like what Dr. Maluccio and Dr. Blakely said earlier, we really need to screen a patient, especially with high serotonin, for carcinoma heart disease, especially if they may go for surgery, because that may also cause other complications. I think that's also relevant.
Yes, I would conclude I agree with everybody. I think it's really important. The key take-home message here, guys, is to be aware of this rare complication, because once it sets in, it really affects the overall survival. Right, so it's really important if you're seeing a community oncologist, and if you have carcinoid syndrome or if you have elevated serotonin, then talk to your doctor about, hey doc, are you checking me for carcinoma heart disease? The incidence of carcinoma heart disease is under 5%, so it is a rare thing. But in those where it happens, it can significantly impact longevity as well as the quality of life, right? And talking, building on Dr. Del Rivero's point, there is documented evidence if there is 7 to 10-fold increase in upper limit of normal serotonin levels, the overall survival is actually 50% reduced in those patients. So we always strive to lower the serotonin beat with sandostatin, lanreotide, surgical debulking, with a lot of these things. And why is the mortality high? Is because of these complications, causing heart disease, mesenteric fibrosis, and a lot of other things. So it's really important to be aware of this. Don't be overtly worried as well. As long as you've been screened at baseline, at our center we do echocardiogram, some data from MD Anderson Cardiology Division in favor of pro-BNP. That's also good, but echo at the very least, because if there are some echo changes or there's some valvular changes, you definitely need to see a cardiologist early on and have close monitoring, while your oncologists and surgeons are working to lower the burden of serotonin in your body. Okay. All right. With that, we will conclude, and we have a wonderful lunch now. And we will regroup again in the afternoon session. Thank you, everybody, for your time.